My name is Susanna Looney. I am the current president of the American Society of Addiction Nursing. Can everyone see my screen?
Yes.
Yep. Yes.
Okay, good. Okay, so this is our monthly webinar that we've been hosting throughout the year of 2023, and tonight is entitled Evidence-Based Contingency Management, a Game Changer for SUD. Okay, this webinar has been approved for 1.0 Nursing CE through the California Board of Nursing. Please complete the survey. That should be the survey. It'll be sent by email at the completion of the webinar. And then you will receive the certificate of completion with the CE upon verification of, the survey has been completed, and you'll receive it within probably 5 minutes. If you happen to miss a session, or if you're interested in any session that we had previously done, they are archived on our website, and CE again is available for each survey you complete and you'll get a certificate. And all the webinars are free to all of our ASAN members. And if you're not a member of ASAN, I strongly encourage you to become a member. We're a very inexpensive organization to join, and we have a lot to offer to our members. And just a reminder to please keep your cameras on, mute your microphone so not to distract the presenter tonight. And if you have any questions, please post them in the chat box. It's at the bottom of your screen. And Jill had said that she will answer some, and some she will wait to the end of the presentation to keep the presentation moving along. And I want to introduce Jill, who is our speaker today. She is a behavioral health advocate, mental health wellness champion, and a board-certified professional recovery coach. With a profound commitment to her own long-term recovery from alcohol use disorder, Jill established a thriving recovery coaching business focused on behavior health changes, earning an award of excellence in 2020. Acknowledging the existing gaps with substance use disorder treatment, Jill embarked on a mission to advocate for the integration of digital health programs that offer evidence-based behavior health modalities such as CBT, contingency management. Currently, she holds the position of Director of Advocacy and Growth at Dynamic Health. And Jill also advocates for stigma-free environment for substance use disorder, which is reflected in her 2020 cover article in Nursing 2022. I strongly encourage everyone to peek at it and read it. It was entitled Destigmatizing Alcohol Use Among Nurses. I will stop sharing my screen and I will hand the webinar over to Jill.
Geez, you know what? When I'm introduced, I almost am like, who's that? But thank you very, very much. And I'm just I feel like I'm with friends whenever I'm talking to nurses. I have had an active nursing license now. I don't even want to say how long, but since '83. And the article that Suzanne just referenced, I'll just hold it up. I was asked to write this article, and this ended up felt like a mini little thesis. And I am sort of known as a bit of I guess at this point by default, a subject matter expert with alcohol use disorder, and in particular with nurses. But I have so many other interests, and behavioral health is at the top of the list. So that is what we're going to be addressing. I do want to just say that my slides are all grounded in science, of course, but I will occasionally speak from a person in long-term recovery or as a person as a recovery coach, because I have had so much experience coaching primarily women with alcohol use disorder. And then last, full disclosure, as was mentioned, I do work for a company, Dynamic Care Health, that does offer a digital health program. But I also, there's no buts. In this program, I will share the very short list of companies that do offer this type of modality. And I'm sure it's growing, but I'm here to share all. So, okay, so let me just get started here. The objectives, and I'll tell you, when I originally wrote these, and then when I developed my presentation, I feel like these objectives are just a teeny little bit of what I'm going to be sharing. So in addition to this, I hope to create interest and a vision for you to bring evidence-based contingency management to your practice. I hope that it really garners interest in and in understanding it, how it can and should be used in treatment of substance use disorder, and how it's a part of the continuum of care. And also, what is keeping it from being readily used, right? And then the solutions to overcoming these challenges. So I have a chock full presentation. If I feel like I'm going over time, I may speed it up, but I'm so happy to be here sharing this with you. I always start with sort of one graphic that I know we all pretty much know this information and what we're facing, but just to really give it a perspective is back, in 1999, 2000 is we started with the issue of prescription meds. OxyContin, it was the leader, but opioid prescriptive meds. And that developed into, once those prescriptions potentially slowed down, although they didn't always, but that did develop into a street heroin problem. And then along the way, we became inundated and problematic with fentanyl. And now fentanyl is being laced with stimulants. And so in this last 20 years, which is most important is what's happening now, we are faced with a polysubstance use problem. They're calling it the fourth wave. You may have heard of that. But the Pew Research is calling it the fourth wave because the stimulant use is just skyrocketing, and overdose deaths that can, the toxicology reports are coming back with the combination of opioids with stimulants. So I just want to frame that. I think that opioid use disorder and the opioid crisis got so much attention, and the settlement dollars, which need to be here, and this is all very exciting, but we actually have a stimulant use problem that is really rearing its head. So what are we doing to address this? I'm not going through this list, but just I think it helps ground as we move forward. Every single thing here is so important. Everything has a role. Many of these are used or should be used in combination with others, of course. So I am going to be focusing on behavioral health, which is why it is highlighted. And in terms of behavioral health, again, I could just speak an hour about behavioral health and resisted the temptation to have any other slides about it. But very big picture, behavioral health is all about changing behavior. That's why it's called behavioral health. And cognitive behavioral therapy is about understanding how our thoughts impact our behavior. Motivational enhancement therapy addresses the motivation behind what is affecting our behavior, and community reinforcement approach is the natural reinforcers that ultimately are important as we make our way through recovery. So very quickly highlighted what each of those are, but contingency management is what we're talking about today. And it's its own little category there. So it is quite interesting that contingency management, I'm going to go out on a limb, and I've heard people say this many times, so I am going to say it as well, that there is no intervention for substance use treatment that has been more researched than contingency management. It is actually almost, it's unbelievable how much data is on contingency management, and it's still not mainstream today. We have had over 100 randomized controlled trials. There are 12 meta-analysis. The NIH started researching this 40 years ago. The data is always consistent. It doubles abstinence over treatment as usual, right? So let's just let that set in. It always, over this 40-year span, consistently, research shows that it doubles abstinence over treatment as usual. Now, think if we said that about diabetes or cancer or heart disease, that a new intervention was doubling treatment as usual. It would be almost malpractice not to use it, right? But as we know, addiction treatment is a whole nother ballgame. There's somehow different rules, unwritten rules and written rules for substance use treatment. And so it's almost hard to believe when you see this language, like, how can that be true? But it is absolutely true. I wanted to highlight a couple more things here with there's actually research embedded throughout the presentation, but this is actually a recent article. I'm going to hold it up. And by the way, I did open up the presentation and we'll close with my contact information. Please reach out to me if you want any of these reprints. I'm happy to give them to you. But Rick Rawson is kind of the godfather of contingency management. He designed the matrix model. He has so much data on contingency management, and he wrote this article about contingency management for stimulant use disorder. Remember back to that graph that I opened up with about how we're really being faced with not just an opioid crisis, but a stimulant and opioid or poly-use substance use crisis. So he is strongly encouraging the powers to be considering contingency management as standard of care for treatment of stimulant use disorder. And why? Is because there is no other FDA approved medication for stimulant use disorder like there is for opioid use disorder. The acronym is MOUD, right? Medicine for opioid use disorder. We're all familiar with that. Alcohol use disorder also has naltrexone, but not stimulant. And so we need to be paying attention with what are we doing with stimulant use. And this is an excellent article. The other thing he does is he highlights all the historical problems and all the recommendations for the future. And I know the legislators are using this document. The other point about stimulant, and by the way, this is not a stimulant use disorder presentation, but I'm opening up with it because it's so front and center. There is a motivational incentive policy group. There's a number of physicians. Rick Rawson is part of it, but I'm going to say there's 20 physicians around the country. And they put out a policy statement that was also endorsed by Hopkins, stating that opioid settlement dollars in all 50 states, which are right now targeted for opioid treatment, they are suggesting that in states that have a stimulant problem, that the opioid dollars should be also used for treatment of stimulant use. Why it's important that Hopkins endorsed it is because Hopkins actually wrote the boilerplate for what treatment and what focus should be used when identifying where those dollars go to. So this is, in other words, like an addendum to where the opioid dollars should be used. And so you may be hearing more about that. I bring that up so you're in the know about a little bit of the policies and the decisions behind maybe where some of this money could or could not be going. All right, so contingency management, broad application, focusing on substance use disorder. Contingency management is highly researched with opioids, stimulants, alcohol, and cannabis, nicotine, and vaping. It can be flexible to treatment goals of abstinence through harm reduction. In terms of its applicability about where it's used, I mean, this is actually one of my favorite parts about contingency management, is that regardless of where someone is, it could be in the ER after an overdose, or it could be honestly being discharged from an OP program. Any time is a good time to start a contingency management program. So as levels of care change, right, and there's multiple settings, contingency management is adjunctive to anything else that could be going on. And that's why, regardless of the setting, there is a role for contingency management, and it can be used throughout the country. And most data is anyone over 13 years of age. So let's look at the fundamentals of CM as a scientific learning strategy, because that is exactly what it is. Now, we all learned about different kinds of learning and conditioning in high school, college, both in biology and sociology. And classical conditioning is the association between a stimulus and a response. And what made this famous is Pavlov's dog, right? So Pavlov showed that dogs could be conditioned to salivate at the sound of a bell. And if that sound was repeated, excuse me, when the sound, so if that sound was repeatedly presented at the same time that they were given food, they could draw a correlation there. Now, what makes that different from operative conditioning is that there's an actual intervention inserted after a behavior is shown. And that is either positive or negative reinforcement, or it could be punishment. So the most common reference here is the Skinner box. If you remember Skinner box, that really gets the cobwebs going, right? And that is where a mouse inside a box learned to press the lever for a pellet of food when the light was green, but the mouse would get a slight shock when the light was red. So he only got the pellet of food when the light was green. So he started to associate the two. And so that is just kind of those early experiments that we learned, the different kinds of conditioning, classical or operative. And contingency management is an operative conditioning approach using positive reinforcement, not negative reinforcement and not punishment. We're going to talk a little bit more about this. And I see somebody's on that. I just want to make sure I have a chat. Okay. And again, ask your questions if you have any. And if it's like, I could potentially stop right then and there. Otherwise, I'll take them at the end. So both reinforcement and punishment can change behavior. Okay. We sort of know this. But there's so much more to gain with positive reinforcement, which is why contingency management is one of the many reasons why researchers have been fascinated by this approach. So with contingency management using positive reinforcement, it teaches new behaviors in a way that builds self-esteem and self-motivation. In other words, it gives a person their agency. Punishment reduces self-esteem. We may get some of the same end results, but we're really kind of destroying the person in the process or parts of them. And so positive reinforcement is the way of contingency management. So let's look at this a little bit more. So a behavior occurs, and then there's a positive reinforcement or a reward. So I'm going to start using the word reward. Another word is incentive. They are incentivized. But let's just stick with the word reward for now. There's a behavior, they're rewarded. So a person is likely to repeat the behavior because they want to get another reward. So what is happening here is that we're rewiring the brain. And there is a term called that I'll just state it. It's a phrase. I love this phrase. It's neurons that fire together, wire together, and neurons that fire apart, wire apart. Okay. And this is how habits occur. I mean, this is just interesting, right? So habits are all about, we are trying to, it's a neuronal, let me say this right. It's a neuronal ensemble. It was a psychologist in 1949, Donald Hebb, and he's the one who coined this phrase. And he basically said that when we do the same things and achieve the same benefits over and over again, that our neurons become either wired apart or together, depending on what we are doing. And overall, the system is teaching habits, accountability, motivation, and self-esteem all rise. And some of this work is in that book called The Power of a Habit. Charles Duhigg wrote that. It was very popular about 10 years ago, and I read that when I was in recovery. So let's look at the brain reward system of which contingency management affects. So this is a nice little graphic that shows that when something pleasurable happens, it activates the brain reward system. The body, we feel good and dopamine is released. In fact, dopamine is released and we feel good. It's So what comes first, the chicken or the egg? So egg. So we need to understand that when something is pleasurable, it's a dopamine hit, a dopamine release. And this happens every day. We wake up, we see a text from a loved one. Oh, it feels good. That's like a little dopamine hit. Exercise, nutrition, general nutrition, and that supports the body is also supporting this. But there are other things that are very kind of radically can affect this. And chemicals is one, and alcohol is on this photo here. So a person takes a drink, they feel good, it activates the brain, dopamine's released. And they're like, oh, this is really fun. I'm going to do this again. Now, not everyone ends up problematic, as we know, but there is a group of people that get in this loop, and this goes over and over and over again to the point where the dopamine levels go haywire. Sometimes they're very high, but so actually then they drop below baseline. It takes more to even get a normal response. The entire system becomes out of balance. Addiction is a dysfunctional brain reward system. Amongst other things, it is that. And so in turn, there is a actual pharmacobehavioral theory of substance use. And it really comes down to that psychoactive drugs, they are reinforcing this behavior. Then they are hijacking the brain reward system, right? Because they make us feel good. They remove negative feelings. And then they start to supersede what has typically brought someone pleasure. That is when you know your brain reward system is definitely off kilter. So let's talk about where the brain reward resides. And this is so important. You know what? This may be potentially the most important slide I give. To me, this was an aha when I first really fundamentally understood this in my own recovery. So our interventions, I did a slide that talked about all the interventions that we offer people. A vast majority of them are being, are influencing our prefrontal cortex. And the role of the prefrontal cortex is where our reasoning is, where we learn our decision making. So that is very, very, very important for sure. But if we only focus on that, which is what substance use treatment was for so long before MAT, we're really kind of tying our hands behind our back. We must get to the root of the brain reward system. And that does not live in the prefrontal cortex at all. That lives in the limbic system. And that the role of the limbic system is it signals reward and triggers pleasure. Like this is where our sexual drive is. This is where the dopamine lives. And so what is going to affect the brain reward system and help it heal are really fundamentally two to three things. Medication. So this is where medication-assisted treatment comes into play, because it is treating the neurotransmitter pathway that live in this system right here. And also the rewards, right? Or sanctions like the carrot or the stick. And we're focusing on rewards, which is contingency management, or CM. And so this is why contingency management will double treatment as usual, because it's like a two-prong approach versus a single pillar approach. If we add contingency management to anything else, it always increases abstinence and time in treatment, which are the two biggest measures. So I just really want this to really sink in on where various modalities are helping. Even cognitive behavioral therapy is actually working at the prefrontal cortex, right? Motivational interviewing, prefrontal cortex. But MAT and contingency management are solely at the brain reward system. Okay, so let's come back to this graphic and let's talk about evidence-based contingency management. So what makes contingency management evidence-based? The prior slide with this, and I didn't mention this, is we all were kind of exposed to some forms of contingency management, either growing up or even the 12-step programs where we would get first a daily chip and then a monthly and yearly chips. I mean, that feels good when we are rewarded in that way. As children or at parents managing children, like we would give stars when they would complete certain tasks, right? Complete their chores, they get a star. Those are kind of forms of operative conditioning. But when we say evidence-based contingency management, what are we talking about? And so this is where it's all about, it's a protocol-driven mechanism with a preset schedule of incentives or rewards that usually are of a value of, it can be anywhere from $5.99, I mean, this is in the research, up to $2,000. Most programs stay under $600, so there is no tax consequence associated with these rewards, which are in the future. These rewards will be considered medically necessary and considered medical care, and so you'll see them go higher. But until everything catches up, this is considered income, and we don't want any tax consequences with anyone, so they keep it under $5.99. These are the few programs out there keep it under $600, so it's $5.99. If this is confusing, I can go through this again. So as the value, and so how this whole process goes is that there is a staggered approach, because these rewards are competing with the pleasure of the substance. So they need to be interesting enough and frequent enough to compete with the substance. So how this usually works is, I'm sorry, did I just lose? How this usually works is that there are frequent rewards over a given day and week. So they are frequently rewarded and getting the dopamine hit with the brain reward system with smaller amounts of value. And then over time, as they graduate and grow, then it's higher dollar amounts with less frequent rewards. And we're going to just continue on. So back to this graphic, what contingency management is in this particular example is a person is asked to take a substance test, which is one of the key markers. We are encouraging abstinence. How do we do that? We substance test. So this is a breathalyzer. So a person blows into a breathalyzer, and it's a 0, and he's rewarded with deposits on a smart debit card, for example. It could be a coupon or a gift card. There are other ways that rewards are given. And this activates the brain reward system, and dopamine is released, and the person feels good. Their self-esteem goes up. They feel satisfied. They're doing great. They can feel good about the recovery. And then this gets repeated. So over time, we just need to understand that we are healing people. You know, we are healing them emotionally and mentally, but we are healing them physically. I love this graphic, or this graphic, because it shows that a healthy control, and this, by the way, is the brain reward system here. 1 month of abstinence and then 14 months of abstinence. And it's not exactly quite back to normal, but it is pretty darn close. And as we know, the longer people are in recovery and abstinent, that the greater chance they are of a sustainable recovery. Now, this is an interesting study that is just so interesting. I had to share it with you. This is actually old. So this is 1994, but this gives you a sense of how long people, the experts in our field, have been looking at this. And so basically what this is, I actually had a physician explain this to me, but generally speaking, what this study was all about is they were giving people with cocaine use disorder a choice between a line of cocaine and a monetary reward. This is the study, right? So a line of cocaine or a monetary reward. There were a series of 10 choices, like 10 sessions. And there was varying dollar amounts that they were offered. And what this graphic shows is that 8 out of 10 times when somebody was offered a nickel or a line of cocaine, they chose the line of cocaine. 6 out of 10 times when they were offered $1, they chose cocaine over the dollar. But when somebody was given $2, they chose the $2. Wait, I just want to make sure I'm saying this right. So, in other, I'm not 100% sure I said that right, but let me just summarize on this graph. Bottom line is that with just $2, only 2 times out of 10 did the person choose cocaine. Let that sink in, right? In other words, it doesn't take that much value of reward to get someone to move forward. And this got everybody's attention, right? So a nickel, not going to move the needle. $1, not so much. $2, wow. 2 out of 10 chose $2. That means 8 walked away. I'm sorry, 8 out. Wait, I'm saying this wrong. So 2 out of 10 times they chose cocaine over the $2, which means 8 out of 10 chose the $2. I'm sorry, I'm getting hung up on this. Okay. You with me? Give me a thumbs up if you're with me. Thank you. All right. So I always feel it's important to show data. And so hopefully you're appreciating this as well. This is I can also provide you the full meta-analysis on this, but this is a 2018. So this is relatively current meta-analysis that reviewed 50 trials of behavioral health. 50 clinical trials. There's almost 7,000 participants, and they compared outcomes to 12 different behavioral interventions versus treatment as usual. Okay, for cocaine, methamphetamine. So these are tough people, and what they found, because you can see the key at the bottom. Actually, my pointer's not working here. Well, but at the bottom you can see the key where there are lines. There's blue, green, and turquoise, and so on. And basically, what it showed was that contingency management plus community reinforcement approach, which is, to be perfectly honest, which is what the digital health programs that are out there right now are doing. They open up with a strong contingency management program and they morph into a community reinforcement approach that had the abstinence at the longest follow-up. And so this gets very heady, but it's very, very important. So this combination had the best chance of success. So contingency management is also extremely cost effective. I was on a call today with a doc out of LA who had done all his research, and he was giving me more data than I had about how cost effective contingency management is over what it costs for any of the treatments that are available. But in this particular study, what I can tell you is that the Washington State of Public Policy, which is an independent think tank in the state of Washington, what they did is they analyzed all the different interventions out there and what they cost and how effective they are. And what it showed is that for every dollar spent on contingency management, it saves $39.30. So just call it $40. And that it had a 77% chance of that the benefits will exceed the cost. So 77% chance that this is so. And so so contingency management outranked counseling, CBT, motivational interviewing, relapse prevention, 12 steps, and other commonly used and very important treatment like MAT. So again, I just want this to sink in that this is cost effective. So I talked about this early on in another slide, but I want you to get a sense of all the continuity of care and the different bridges this offers, different treatment programs. whether we're looking at and the like inpatient to an IOP or an OP. Anytime there's a transition, we know that's the risk when people will drop out. Then when there's a change in the level of care, or could even be a change in who is giving the care. Transitions from incarceration to reentry. So you may be hearing about contingency management and CBT being used in the corrections arena, both in drug courts and in reentry, and actually also during incarceration as well. And so all of this said, when all is said and done, it also is effective as a standalone treatment. These are the patient population. It is not in other words, I hit the highlights here, but again, emergency departments, pregnancy and postpartum women. Yes. This is a group near and dear to my heart. There is a lot of emphasis on opioid use disorder, substance use disorder in general with pregnancy and postpartum women. And this is a beautiful opportunity to engage contingency management. And it also will help social determinants of health because you're infusing some value into their life, monetary value. Most people who are in these programs and gaining monetary value are using them to like pay an electric bill or grocery bill. So it's huge success that helps the social determinants of health angle. And we also have studies on that. Adolescent population, so perfect for contingency management, especially digital, because they love their devices, right? They love their devices. So it's working really well. I'm just going to actually keep going here. So what makes a good contingency management program? Because they're not, they're not all quote unquote the same, or there are specific things we want to focus on. So now we're going to focus on the rewards. First, we want the rewards to be very specific. In other words, they need to be clearly defined and achievable. There needs to be like a clear understanding of what is expected. Next, the rewards need to be desirable, something that virtually everybody would want. Offering a Starbucks gift card may not appeal to everybody. That is why, with all the data that's out there, by far, monetary rewards do the best. And the reason is because it's easy and everyone likes it. Men, women, old, young, rural, urban can all use money, and it goes. And the sophisticated way is deposits on a smart debit card that it's a smart card and can't be used inappropriately. And I'll address that down the road here. Next is that the rewards are given immediately, not 2 days from now, but immediately. And again, what makes that so is some form of technology, right? Next, contingent, obviously, you're giving rewards contingents on the behavior shown. And then this whole pattern repeats over and over again, right? Consistently. So what makes an overall good process? And some of this might be duplicative, but it's important to share. So again, defining the target behavior, frequently measuring the behavior, and again, evidence-based contingency management, it's usually a preset schedule that has been embedded into a technology program. So it's artificial intelligence that has been programmed, and based on how the person is doing is how it flows out. If there's a relapse, it resets, and then there's more frequent testing, and then it goes back to where they were before there was a problem. It doesn't go back to the beginning per se. Again, it's using the technology at its best. Let's see. Obviously withholding incentives if the behavior is not shown, and then repeating this protocol driven over and over. So I'm going to move on to now, if with everything I've just shared, you're probably thinking even more than you already have, like, okay, then why is this not being used? This slide says a lot, and I'm going to try to clip through it because there are distinct things, obstacles or barriers that are real, and then there are solutions that are also equally as real. And we just need to move people from what they've known to where we're going. So SAMHSA, loves SAMHSA, but unfortunately, SAMHSA has a limit. They will only allow $75 over a full year to be used for contingency management. And that is just not evidence-based. It actually makes things worse. People get confused. They think, oh, well, contingency management doesn't work. Well, it doesn't work when it's $75 over a year. What's evidence-based is between 100 and 200, but usually 100 over approximately 6 months, or we back it to $599. So you can't compare $75 to $599. You're not going to get the same benefit. SAMHSA knows this. They are trying to change things, but it takes meetings, process, legislatures, and that is happening. Not on everything. We will see SAMHSA eventually make this change. Next, stigma. Unfortunately, this is so still prevalent in all things related to substance use. And the best antidote is education. And another antidote is truth, speaking truth. And I love this new movement going on in recovery. It's called Recovering Out Loud. Now, AA, which I used to go to a ton, it helped me so much. It's anonymous, meaning kind of secret. And the subconscious is saying, wow, no one's supposed to know about this. It kind of, secrets keep us sick. And that orientation was helpful 100 years ago, and it's still helpful to many people now. But for other people, including like the providers that are working with this, it's so much better to recover out loud. I'm in recovery from long-term, from alcohol use disorder. And it has really freed and released this momentum, and it's helping the stigma. All right, I'm going to get off my soapbox about that, left over from this article, which has so much in there. Financing. This does have to do with SAMHSA a bit, but also just in general, Medicaid and payers have been trailing in the payment for this, but it is happening. I happen to know Blue Cross Blue Shield of Massachusetts and New Jersey completely pay for contingency management, right? You might not have known that. That is really key. Virginia is right behind them, and Pennsylvania, Allegheny County, right behind them. So little by little, these pockets are saying, hey, time out. This is so much more cost effective than what we're doing. Let's get started with this. And I really think we are about ready to see this wave coming because people are asking the question and seeing the data. So that is coming. Management logistics. This is another super important thing. Maybe you're aware that around the year 2000, maybe 2002, there was a treatment center in California that best intentions, but didn't keep very good records about where their rewards were going. And they got their hands slapped, and it kind of freaked the whole country. Everybody pulled back. If there was going to be a little movement on CM, that kind of put it on hold because there was a concern that they were violating the anti-kickback statute of paying people unnecessarily. In fact, this is all pharmaceuticals. You're not allowed to pay people for their treatment. So this really slowed things down. finally, and I'm going to go through this in the next slide, there's actually a list of the guardrails. It's like a checklist of you need to make sure you're doing this and this and this and this, and then you're good to go. And a lot of it is just good records. And in the past, CM has been very manual, like, oh, okay, well, Susie, she did this and she had this urine test, and then we gave her a $5 gift certificate, and it's very manual. Well, with technology, it's all automatic now. It's seamless and scalable. So the technology is making this problem like a way of the past. And then last is this variable efficacy. I addressed this with the $75. We need all evidence-based contingency management to be implemented generally the same. We need to make sure we're comparing apples to apples, not apples to oranges. So this slide just is really just to address that. The contingency management was written in the White House plan in 2021 and 2022, specifically stating the language, motivational incentives, which utilize tangible rewards to reinforce positive behaviors. Like, this is the language. This is in our national drug control strategy. So at the top, people are on board. We just need it to filter through. I'll just keep going here. So this is the checklist that I spoke about, and this has the blessing of the Office of Inspector General, which is sort of like the FDA for pharmaceuticals. The OIG is sort of the governing body for contingency management. And if you just take a look here, you need a research validated protocol, right? Rewards should not exceed 200 a month, because that's in the data. That's why that's there. A documented clinical diagnosis, a substance use disorder diagnosis, and a care plan. Individualized care plans documenting the behavioral targets. Like, basically all of the markers, all of the details of contingency management need documented. Well, you think about it, if you're like in charge of that manually, that's overwhelming. But again, this is why there's a new technology has changed what this can and has become for us. Full accounting of every payment. In other words, you need to be audit ready. Should somebody say, okay, I want to know how much has been paid to such and such and da, 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 da. You need to have that like that, and so forth. No, I will wait. And when I say and so forth, I do want to just say that contingency management cannot be used for promotion. You cannot say, hey, treatment center XYZ is offering payment. No, it is not offering payment. This is a medical necessity, a scientific based protocol. So we don't want to get tripped up in what it's not. And so they're very crystal clear on that, because I think, like, long time ago, there may have been some abuses along that way. So this is like crystal clear here. It's maybe the second important slide I share. So we're coming down. I'm not doing that. I have about 10 more minutes, and I'm going to take questions. And I hope you're enjoying this as much as I am sharing it with you. So this is kind of the short list here of digital health options related to substance use disorder and contingency management. I'm actually going to drop down to bullet point number 4. If you have heard about contingency management or CBT at all, it would have been because of Pear Therapeutics had 2 products out. One was called Reset and one was called Reset O. Okay, if I'm a show of hands, has anyone heard of this company or these 2 products? Anyone? Are you with me? No one's heard of them. Oh, thank you. Okay.
Not heard of it.
Fran?
Not heard of it.
Okay. Anybody want to comment? Did you use it?
We used it briefly in outpatient, not for long, because the counselors had an aversion to patients being rewarded for doing the modules. But the main draw was you had to have a prescriber sign, it was a prescriptive so that New Jersey Medicaid would pay for it.
Got it. Okay. Thank you for sharing that, Rosemary. Okay. So yes, good feedback. So first, and Gail, you may not, I assume, actually, I'm Rosemary. Actually, you know what? Your square just flipped where you were. So Rosemary, I was talking to you. Yeah. So I don't know if you know this or not, but they're no longer in business. Did you know that?
No, I didn't know, but there were a couple of other physicians in New Jersey who had tried to take that model and make their own,
Make your own.
yeah,
Okay.
yeah.
Okay, perfect. Thank you I appreciate, and I interaction is great. So I'm going to just hang on pair because it got the most attention and it is off the market. It's off the market because the company accidentally mismanaged the money and they're no longer in business. But what I will tell you about Reset and Reset O is they didn't really do anybody any favors. They said they were a CM program and they actually weren't. But I put it on here just because I'm trying to be thorough. See, they were primarily, first and foremost, a CBT program. Some in this arena will say they are only a CBT program. They got FDA approval, and their package insert was because they were a CBT program and they were supposed to use another contingency management program. And they just sort of slid a mini one in, and it was not very effective. So like I say, it wasn't doing anyone any favors that was doing contingency management properly. But I have heard that CBT these are self-study, right? I just want you all to know this. Self-study is what we're talking about here. And so counselors, I can understand, and I have heard that before, aren't too crazy about a digital program basically taking over their job. And especially when that is the primary thing getting rewarded. So, all right, enough on pair. So Dynamic Care at the top, the first bullet point is a 12-month program. It is primarily a contingency management program, and it has a number of features. It does have a CBT library, and only 10% of the incentives are rewarded because of that. 80% are rewarded for abstinence drug tests, okay? And then the other 20% is attending treatment, so time in treatment. It also has a craft program, which is evidence-based. It's a family program, community reinforcement program. And then they also offer coaching, peer support specialists that coach, and then they coach to the contingency management program. Affect Therapeutics is another fine organization. They also have a digital app. This company is sort of like outsourcing everything. So they do MAT, they have physicians, they have counselors, they have a contingency management program, and they have a CBT library. So this is when it's like in a rural situation where there's just no one around. This is like total telemedicine for the whole cotton caboodle. And it's a 6-month program. As opposed to the first one I talked about is not a complete telemedicine at all. There is no MAT, there is no counseling. The coaching is coaching the system along. And then Q2 Q21, am I saying that right? This one I just became aware of, and it's primarily technology. In other words, it's a digital tech engine, and it doesn't only CM and doesn't offer anything else. And sadly, I don't know much about it. I just became aware of it, and I wanted to be thorough. Quit Genius just changed their name. They're a 3-month program. They are known for MAT and telemed, so similar to Affect. And I just got wind that they added CBT. And since I feel CBT is important, but not CM. I included them in this list. They work a lot with employers, right? So like Amazon, and like these large Walmart, these large employers that want to support their employees with substance use. That's the market they went after. And then last is Work at Health. They also have an app. These people, I believe, come into the home, but I do know they have an app. And they are somewhat in the game here. And I think that they are growing. That is the short list here. And so I'm going to demonstrate a little bit more on the program I know most about, and then take some questions. I did want to mention that one, that remember I showed that guard list, that checklist of guardrails for contingency management by the OIG. So the only company that has been approved for usage is Dynamic Care Health. And it was by submitting all of the material, all of the research, and after a 1.5 year review process, they received an approval letter. And so this was important to the company and important to customers to move the OIG to make a statement, because before that, the OIG was just really non-committal. And so Dynamic Care Health kind of pushed a little and said, okay, here's the program that you asked for. Would you please approve it? And that is exactly what happened. So we're going to talk a little bit about this tech-enabled CM by Dynamic Care. And it is an app, and it's got all of these features as different behaviors or activities are shown or done, some of those will get motivational rewards. And I mentioned the recovery coaching. That is a peer support specialist or board certified recovery coach that meets weekly with the Dynamic Care member to review the past week and go over the upcoming week, because everything is digital and all the meetings are all entered in the calendar. And so when they arrive, the GPS sees that they've arrived at their treatment center for a meeting, and the GPS captures it and then rewards them. The monitoring meds and the remote drug testing, it's random, remote, true witness. If you would like, I can demonstrate right now what that means, because you're probably thinking, how is that possible to be true witness if it is remote? It's almost like doesn't compute. So I will do that at the very end here. I'll keep moving, but this is a key part of this program and other programs that are doing remote substance testing. It is keeping people accountable and motivated to their recovery with key behaviors such as abstinence tests. I mentioned the CBT content. It's a library. It's up to 5 minutes. It's very interactive. And then the family craft program. And that also comes with coaching. It's such an important program. And this system, it's not on this screen, but offers a provider portal and a support portal. So if your physician is a physician recommends Dynamic Care and wants to be like monitoring what's happened, a physician can be as involved or uninvolved as they want. This is different than PAIR's program where physicians had to be involved. This is not that way. It's just, it gives a snapshot of the person's substance test, what CBT programs they have completed and how they answered it, all the surveys, like the weekly surveys and monthly surveys that are standardized in substance use treatment to see how they're feeling, how they're doing, and so forth. So sake of time, I'm just going to keep going here. We mentioned the reinforcing attendance. So again, it's the person would plug it into their calendar. They receive reminders that a particular meeting is coming, and then when they attend, it tracks that they have arrived, and then they've been there for the duration. And then again, the random remote. And actually, you know what? I'm just going to do it right now because this is such a small group and I'm almost done anyway. So I, of course, have the app on my phone and for demonstration purposes. And I'm going to request a test so I can demonstrate this to you. So wait, I'll, you know what? I'm going to let that come up. It'll be up in just a second. So I am going to move on because I do want to demonstrate that. But so the 12-month program, there's this, there's a strategy behind the 12 months. It's broken into sort of increments of 4 months. And the main thing I want you to see is that substance testing and recovery coaching occurs the entire time, right? The entire time the system does what it does beautifully, regardless if people are being incentivized or not. But at the beginning, the motivational rewards, our incentives are at play. They begin frequent, smaller dollars, and then over time, they become less frequent, bigger dollars, right? So we're transitioning people from this immediate gratification that they get with their drug substance. We're basically doing like a baton, like think of baton switch from that substance use to doing immediate gratification with the incentives, but then starting to wean them off. And by the time we're at 6 months, 8 months, they're completely off the incentives. And now the coach is trained to get them focused on the community reinforcement approach, where they're focused on real life reinforcers like going back to school, getting a job, rekindling a relationship with loved ones, saving money for a car, applying for a job. Those are like natural reinforcers that all of us, those are our goals, right? And that is where we move. That's community reinforcement. So there is a transition from the motivational incentives to community reinforcement. And so the 12-month program, though, once the incentives are removed, we keep going with measuring substance testing and the recovery coaching. So that habit that they're in is continuing to reinforce, like, great job, great job. They're getting the great job icon on their phone. They're just not getting the deposits on a smart debit card. And this is our data. We have a ton of data, and this is the only slide I'm using, just big picture to show you how much more effective it is over MAT. So the lower line is buprenorphine, and what we can expect after 12 months of treatment. And the top line is dynamic care. And as you can see, the incentives phase out. And while there is a little dip, it brings back up to almost at 50%. We have people still in the program and abstinent. So coming back to this slide, the technology is the solution to the CM guardrails checklist. And I just changed the header on this because I just want you to really see. I mean, honestly, I could have retitled this presentation, technology, the future of substance use disorder, but it really, digital health is not something to be concerned about or fearful of or confused about. It's something to embrace. It is simply a mechanism to keep everything recorded and organized, just the way our electronic health records do. It is no different. And technology is being used for continued glucose monitoring, sleep apnea, heart rate monitoring. I mean, it on and on and on. And this kind of technology has now arrived for contingency management. Let me just see if my, let's see here. You know what? I had this. Oh, here we go. All right. So here we go. I'm doing a test. So I'm just trying to show you. I think you can all see this. So it's telling me that it's requesting the breathalyzer I have over for the next 2 hours to do this breathalyzer. And that is how these prompts come, is that a person is asked to do either a breathalyzer or a substance test. And that's a saliva test. And that is around here somewhere, a saliva test. And this is also True Witness. And this gets put on a stand. And we are in the visual the whole time. We're doing a self video. and I'm going to show you how this is done. So I'm going to hit start test. So it's telling me not to drive, of course. So I'm going to hit continue. And then it's asking me to set up, and this is Bluetooth enabled. So it's asking me to set up my my breathalyzer, and you can see this is Bluetooth enabled. So I'm saying continue because turn on, it's now connected. You can all see that, right? Can you, right? You can see that I've connected, and now it's asking me I'm ready and to start recording. I'm going to go this way so you can see what I'm doing, right? So my point here is if any time this goes off the screen, this will not be a verified test. This selfie needs to show me and this testing unit, which is a breathalyzer, the entire time. If there's a question about this, it's not verified, and then it's asked to be repeated. So start recording, it's warming up. It's going to do a countdown. It's going to do it this way so you can see. Okay, so here I am. I'm taking a breath. Now it's telling me I'm done. So the whole time I'm, as opposed to me moving it and somebody else blowing in it, this has been like, as you can imagine, researchers want to make sure their testing strategy is, it's telling me, thank you very much. It'll notify me once my test has been reviewed. And that won't take but 10 minutes. And then I will get a deposit onto my smart debit card. It's that fast. So that is a random remote, and random, I did request so I could demonstrate, but of course the random is that at night, on weekends, holidays, random times, this will request the dynamic care user to do a substance test. Okay. The remote is obvious. I'm not in the office, and true witness is because it's been recorded on a selfie video that this system sets up. I don't have to set up like, oh, where's my camera, and oh, turn on my video. It's just automatically. I just keep saying continue, 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 and there it is. So that I wanted to show you. So I'm gonna just sort of stop here. My last slide is because we're at 8:08. I want to make sure I get time for questions. And I see I have a few here. So I'm going to have you read this slide, and I won't go through it because I'm going to start reading, looking at questions and answering those. And then after this slide, I will put my email in case you want to connect with me, is the last slide. So here we go. Let's see. So actually, this is a question that I received that is a fantastic question. And that is that for people who, quote unquote, don't have challenges with their finances, right? They have resources and means. Would this really help them? And honestly, it's not necessarily about the monetary value. It's about the dopamine hit. It's the brain reward system at its best. If you go back to, remember the slide with the cocaine, that $2 was going to really impact whether somebody went for $2 over a line of cocaine. It's the dopamine hit that is most important. Why money, though, is used and is recommended is because it's universally appealing, right? Gift cards can be appealing, but they have to be used at a certain location for a certain thing. And what happens if that person doesn't have that thing or, that location? Just monetary value is so universally appealing, and this is all borne out in the data. So it does work with high. In fact, I was just speaking with a physician who is looking to start contingency management with dynamic care with self-pay clients. Self-pay. So there's no insurance, there's no Medicaid, there's self-pay clients. So it's almost like counterintuitive, like, oh, they're kind of paying themselves, right? I mean, we almost laughed a little bit about it. It's not about that. It's about the brain reward system and the dopamine hit and the habits and the feeling good and the increase in self-esteem and building personal accountability and personal motivation that's contingency management does so beautifully. Any other questions? And at this point, if you want to just unmute yourself and ask, I would love to hear from you. Nice little group here. Is anyone using contingency management right now?
Years ago, I did when I worked on a methadone study back in the probably late 80s. We used it. If they gave a negative urine drug test, they received like a $5 voucher. Every time they gave a negative test, they got $5. It was a gift card.
Yeah. And how did it go?
It went well. It was through Research Triangle Institute years ago.
Yeah. 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 You know what? Like most people think of it, and I didn't have a slide on this, but like the fishbowl method is the term that was used. And the reason they call it the fishbowl method is because there was a fishbowl, literally, that we used to put goldfish in, like the shape, you know, a jar, the shape of a fishbowl that they would put in, like little, they would do drawings, like, and there'd be little pieces of paper, like, woohoo, we got a Hershey Kiss, Hershey Kiss, Hershey Kiss. Oh, Suzanne got a box of chocolates. Like that is a form of contingency management. And the only people that could pull from the fishbowl was people that had a negative substance test and showed up for treatment. You know, if you showed up and, you know, had a either refused or had a negative, it's like, you know, keep trying, but you weren't able to participate in this fun little thing. So that's fun. And it's a form of contingency management, but it's not evidence-based contingency management. And everything now is all evidence-based, right? It's as it should be. Anyone else, like now that I talk about the fishbowl method, does that ring a bell? Do you see contingency management being used in your whatever facility you're in the work that you do?
We're doing contingency management in Washington State.
Excellent, Kathy. Tell me more about that.
We're a small family practice, and we've been doing it for about 1.5 years now, and it's in with the assistance of the Washington State Healthcare Authority and the Washington State University. And we use escalating doses of gift cards, Safeway and Walmart.
Okay, excellent. And how is that going?
Oh, we've been able to see at least one person a month, you know, for that's there's another group in Tonasket, Washington. I guess she's got quite a large group of people that she does contingency management with. But we've probably have seen I'd say 30 people in the 1.5 years that we've been doing this. So, but it's going well. I mean, as long as right now we've lost our funding. So
Oh.
we're using our existing gift cards, and we're working on getting more funding.
Okay. I have an idea for you. Maybe we can talk offline. Because honestly, my job is advocacy, so much education, but it's also working with SAMHSA and the state opioid response teams, and the opioid settlement teams. And it's really been interesting how well, how cooperative and creative people are getting.
Mhm.
So perhaps we could, I'd like to just share a couple of ideas with you when you have a moment.
Okay. I can put my email in, or we can talk after.
Yeah, put your email. Mine's on the screen as well. But I love that. Washington. So I want to say it's interesting. There are pockets all over the country using contingency management. So like early adopters typically are on the coast, right? The East, like the Northeast, the West Coast. But that's not necessarily true. Some of the most robust programs are like West Virginia, Ohio. And again, this is thankfully is not a partisan issue. You would think, again, like maybe the more progressive states would be more open. No. Some of the most conservative states are like, help. So it's really nice to see the cooperation and the trying to figure this all out at all levels. It's just what's been the biggest surprise to me is how much time things take. Like, I'm just, it's like, well, if this is so obvious, why doesn't Samson just change it? But it's like meetings and meetings and meetings and, approvals. And it's just really just takes time. But Washington State, then you probably were, when I showed the slide about the cost, or basically the return of investment on all the different modalities, that was out of Washington State.
Yeah, I had to take a phone call when you went. It was just like you were just starting it, or you just finished it, and I had to take a phone call. So.
Okay, well,
But this is being recorded, right?
yes.
Kathy, yes, you'll be able to see it. Just go to the archive, to our website and go to archives and you'll see the whole presentation.
Okay.
Beautiful. Anyone else? I'm very interested. Is anyone else either using it or want to be using it? Or have a physician or leadership that would be open to, and tackling the hardest patients are usually like, usually how it begins, right? It's like, well, these patients are the biggest trouble, stimulant use disorder. So at least that's been my experience, is that the stimulant use is what is getting people to move on it. So
I found this very interesting. I'm looking to I'm doing recovery coaching, but I'm looking to expand. So this would be very helpful.
nice.
So thank you.
Excellent. Good for you. Are you a PSS?
No, I'm a registered nurse, but I'm in West Virginia, so they did I'm a recovery coach professional through Grace.
Yes.
And that is basically a volunteer position at this time. I'm just looking. I'm getting ready to take on September 8th the CARN test, certified addiction registered nurse. So just putting it all together.
So that's so beautiful. So just to let you know, Dynamic Care is now approved with all the MCOs in West Virginia. Well, there's three MCOs through the Excellence program. Am I saying this right? It's not my account, so that's why I'm a little fuzzy. Excellent. I'm blanking on what it's called. Medicine of Excellence.
I'm sorry, I can't help you. I'm not sure.
Anyway, I do know the MCOs. There's three of them. Medicaid funds it.
Aetna, yes.
Aetna, and then there's two others. So you're West Virginia, you can ask for just ask for the contingency management protocol, but it's up and running, and they've had a huge success with their stimulant use. In fact, they had a pilot, and the numbers actually are better than even our average. It had such an impact. So you will have access to it.
Good, thank you.
Centers of Excellence. Yes, So the Centers of Excellence for Substance Use Disorder in West Virginia with Medicaid are covered. Anybody else?
Any other questions while Jill's here with us tonight? Okay, well, I'm going to end this webinar. And Jill, I want to thank you very much for this really informative presentation that you graciously provided to our group here in our organization.
My pleasure.
Everyone who is on this webinar, you will receive a survey following the webinar. Please fill it out, provide us some feedback. We like to provide our speakers with some feedback also. So please do that, and you'll receive your certificate probably within 1 minute after you submit it. And if you miss some of the presentation, it comes pretty quickly. And if you miss any of the presentation, like Kathy, you mentioned you had to step out, please go back on. You already had paid for it. You're able to access it again. And Jill's phone number, her contact information will be available for everyone who's here.
Yeah, and thank you all so very much. I really applaud your interest in this topic and your professional development, commitment to yourself. I do want to just say, in a couple of years from now, you're going to be like, oh, I listened to this presentation a couple of years ago, because I really think that we are about ready to see a big shift, and with contingency management and behavioral health in general. So, and it's refreshing that it's coming.
And I'm anxious to see ASAM's clinical guidelines.
Yes. Okay. Yes. I guess you all saw it in the chat bar.
Yeah.
So yes. It's very, very exciting times. But ASAM is about ready to come out with a statement about stimulant use disorder. And I think that's also going to really rock us, our community, in terms of opening up opportunity for our patients. And again, it's just, we need the government to release and remove like certain barriers there. That SAMHSA $75 is a big nut. And when that gets removed, yeah, you're smiling, Kathy. Yeah, that is the nut. It's just that simple. Because SOAR grants, state opioid response grants, have to abide by SAMHSA's rules. So it's just that. But meanwhile, it's been very creative, and I've been really so pleased with how well the community has rallied behind it. So anyway, I thank you all very much.
Okay, thank you. Everyone have a good night. And
Thank you so much. Appreciate it.
Yes, thank you.
Have a good evening.
Good evening.